Okay, I think it's time to start now. Good afternoon, everybody. It's my pleasure today to introduce Martina Valente, who is a postdoctoral research at Crimedim. She has extensive experience in mental health, which I'm sure that she'll explain some more. And today she will be with you for the next 1 hour and a half. So Martina, floor is yours.
Thank you, and thank you guys for being here today. I hope you can hear me well and see myself. Now I will try to share my screen, so please let me know if you can see the slides. So can you?
Yes, we can hear you, we can see your face and your slides.
Okay, perfect. So then I will start, and as Georgia mentioned, it will take around 1 hour. I also wanted to introduce a little bit my background and the reason why I'm having this lecture. So I'm not a psychologist, but I'm a global health researcher. So my field of expertise and my background is in global health research. And my interest and my PhD have been in the field of global health. And so that's why also I'm providing this lecture today, which will have more a theoretical nature, while for any practical exercise and practical experience on the field, you will have, if I'm not wrong, as the subsequent section will be about a more field experience with my colleague, Marcello Peirot. So if you have any questions throughout this lecture, throughout this presentation, please feel free to just interrupt me and ask any question, or to go like faster or slower. Okay, so this is the outline. I would like to start with some general global mental health estimates, just to provide a bit of a context on global mental health. And to give you an idea what are the most prevalent conditions and what's the situation in ordinary times. Then I would like to focus on what happened during COVID as a case study to help you to understand the impact of disasters on mental health, since this is an experience we all have and we all can remember vividly. Then I will briefly talk about the impact of disasters on mental health in general, but the second part of this presentation will be centered around the main guidelines for mental health and psychosocial support in emergency settings and during disasters, and so on the response on what to do and how. And then I will conclude with possibly some examples if there's time, and I will give you some resources and references that you can access anytime. So just to start, I wanted to show you some maps just to give you an idea of the overview of global mental health. So this is the share of population with mental health or developmental disorders in 2019. As you can see already from this map, there's quite a high prevalence of mental health disorders in several regions of the world, even though we cannot perceive a real pattern in terms of mental health conditions and socioeconomic index of countries. So we cannot see a pattern according to high or low income countries, at least not clear as for other conditions. If we had to, for example, portray the infectious diseases, the distinction between high income countries and developing countries and low and middle income countries would be much more relevant. In this case, we see quite like a spread of these conditions, even though we see some low and middle income countries with like rather a high prevalence of mental health disorders. We will see then in a minute also what is the reason why we have these like a rather it seems like a lower prevalence of certain mental health conditions in some poorer regions of the world. So these are on the left, you see other two world maps. One is about the share of the population with depression, and the other, the share of population with anxiety disorders. Also here is just for your information. And these two disorders, because these are the most prevalent mental health disorders worldwide, so depression and anxiety disorders. Also here we see some different factors actually among the two different maps. We see some prevalence of mental health conditions of depression, in particular in some low and middle income countries. But as you can see also for anxiety, for example, Australia or the US have some quite a dark color. On the right, instead, we see a diagram which represents the social determinants of mental health. So I'm not sure how many of you are familiar with the social determinants of health in general, but this means that health is not only determined by some biological factors, but rather by different factors, among which also social factors, community-related factors, demographic factors, etc. And this diagram shows all the different factors that affect mental health, from the one that are more proximal factors. So as you can see, age, ethnicity, gender, trauma, distress, and some more like proximal factors that are closer to the individuals. And then we reach more distal factors, which are other factors that still have an influence on mental health. For example, natural disasters, as we see here, war or conflict, but also community and social capital, economic recessions, etc. So there are different factors that impact mental health that in this diagram have also been interestingly placed within the SDGs, the Sustainable Development Goals. Already this diagram tells us that mental health is not only a biological thing, but that's also why we talk about mental health and psychosocial well-being, because there are many social factors and social determinants that have an impact on well-being of people. And this is a world map, which is a bit old. It's 2011, but it's still very relevant, and the situation isn't changed a lot in recent years. But this map shows what we call the treatment gap. Treatment gap means that despite different prevalences of mental health disorders, as we saw in the previous slides, there's no difference, not a lot of difference between high and low income countries, but mental health conditions seems to be quite widespread across many different countries and different regions of the world. However, the prevalence of psychiatrists and mental health workers in general, so the proportion of psychiatrists per general population is very different. And in this world map, we can see very prominently a distinction between high income countries and low and middle income countries. So if mental health disorders do not, let's say, discriminate, they are widespread across all the different world regions, the way mental health is managed and the number of mental health care workers per number of people, as well as the type of the number of people that are diagnosed or that can access mental health care is very different across different regions. And so here socioeconomic factors as well as social stigma play a huge role. So this is in terms of mental health, global mental health in general. So the concept of the treatment gap is quite essential to the global mental health discussion around mental health. But now we are interested in mental health and disasters. And so we might wonder what happened during COVID-19. And this is something everyone can recall on our own experience, on our personal experience or the experience of our community, of our country, of our workplace. So during COVID-19, as soon as COVID-19 spread, but in general during the pandemic, there has been quite an increase of certain mental health conditions. So in the WHO graph, like the bar chart we see on the left, we see an increase in depression and anxiety disorders, which are the most prevalent, the most common conditions. So for both of them, there has been an increase during COVID-19. And if we observe the graphs that are in the middle of the slide, these are graphs that represent the suicide rate in Japan. And we can see that there has been, while suddenly there seems to be quite a decrease of suicides, especially after the first outbreak After, like during, for example, the second outbreaks, we can see a sharp increase in suicides for different, like for males and females and different age ranges. Suicide, as we all know, is a known condition, is a known factor associated with mental health disorders. Here I reported some graphs that I wanted to show you because I think these are quite explicative for the impact of social factors during disasters on mental health. So in the graph that we see on the left, we see that work-related factors had an influence on mental health conditions. We see both for anxiety and depression. We see different lines, different stratifications for people who were employed, unemployed, and with a short-time work scheme. The light blue line is for unemployed people, and in both graphs we can see that at the end the prevalence is higher for both of them, and work-related factors, in this case, like work security, employment, type of employment, etc., are important social factors that contribute to psychosocial well-being of individuals. Same happens for the graphs we see on the right. We have, it's for Europe, we have 3 different examples of France, the Netherlands, and the United Kingdom. And we see the gray symbols, so the gray line and the gray dots represent social factors related to the type of disaster, in this case related to the pandemic. So we see a line which represents the stringency of the containment measures, and the dots that represent the excess deaths. And in all the 3 graphs, we can see that there's some relationship between stringency and excess death rates, and depression index and anxiety index. So for France, you can see that when there's like a peak of deaths, there's also a peak of depression and anxiety index, and and these indexes seem to follow the stringency measures. Similarly happened for the Netherlands. You can see the peak in anxiety represents peaks in death rates, also here for the Netherlands, and same happened for the United Kingdom, precisely for the stringency measures. As you can see, it's quite related to the stringency measures, and the index was quite high. And this tells us a lot about the importance of social factors, both in ordinary times and disasters, during the relationship with mental health conditions. So now I have a question for you. Hopefully some of you can answer to this question, can help me answer into this question, because it's something that it's very easy and we can think about ourselves, our experiences. So after looking at these graphs, if I had to ask you what factors cause mental health to deteriorate during the pandemic, so what are the factors that might have led to some deterioration in our mental health and psychosocial well-being during the pandemic? Can you name some of these factors? Just some examples, random. Please, I saw one hand raised, so just share without raising your hands.
So I guess more time spent alone, social isolation, so like fewer social interactions, and just impacts mental health.
Mm-hmm. Correct, yeah. That's for sure a very important factor that played a role in that. Other factors?
Yes. Maybe another factor is that people lost their jobs, and they are worried about money and financial status.
Mm-hmm. Financial insecurity, of course, yes. I see another hand raised. Please share.
I just want to add that maybe the lack of access to the right, to help in general, people who are struggling in their households and they had to stay at home during quarantine. This also may have deteriorated the mental health related to abuse in general.
Yes, a very good point. Very good point.
I would like to add, maybe it's like the mortality of relatives due to COVID-19 infection.
Another very good point, exactly. This was also playing a very prominent role. Can you think at other factors? You named already many of the factors that are listed in the slide, so I will just show you the one that I noted down, and indeed many of them you already mentioned. So just 1 second, I see. Also the headlines, the pandemic, it says cause fear and panic of people because mental health will deteriorate. Exactly, and that's also a point that is listed on this slide. So first of all, like starting from the basic, the fear of infection and the fear of dying, which might have affected many people. If we think about people with pre-existing mental health conditions, with pre-existing anxiety disorders, for example, might have been impacted by the fear of infection and the fear of dying. But at the same time, also the fear of losing loved ones, missing funerals of loved ones, especially in case of the elderly or people with some vulnerable conditions. At the same time, also socioeconomic and social factors as the fear of losing jobs and livelihoods, the economic insecurity are very important factors. Together with social isolation, the separation from loved ones, if you think again, if you consider the elderly or any people in institutions, for example, increased domestic violence and abuse, anxiety due to being overwhelmed by information and misinformation, as was mentioned earlier, but also the uncertainty about the future and the feeling of feeling lost. This is probably something that characterized many young generations, as well as like students or simply medical doctors who had to be involved in the pandemic response. And then I read recently a paper, and then they felt lost about their future because that was not a choice they had. They could like ponderate or could think about. It was much more something that was needed at the beginning, and many of them had some impact on their like anxiety, feeling of lost because of the contingency choices that were made during the pandemic. So as you can see already from here, there are many psychological, but also many social factors that have deteriorated mental health. So if we had to, let's say, systematize this factor into some sort of diagrams, I would show you these type of graph, to which I added a few things. So if we have to conceptualize the impact of disasters in general, the pandemic in this case on mental health, we can think about two types of reaction. One, which is a positive one, which is resilience. As you all know and probably have heard already about, the resilience is this ability to bounce back and to resist the negative impact of a shock, being able to absorb, to adapt, and to transform into something which can be even better than before. But then we have a negative impact, which can assume several forms. So first of all, we might start from some health risk behaviors, such as, for example, increase in smoking, or alcohol consumption or drug consumption, over dedication to certain unhealthy activities, as well as change in travel, separation from the close one, and some like minor anxiety. So these we can conceptualize as health risk behaviors. Then we can have some distress reactions, such as the change in sleep, irritability, isolation, avoidance, decreased sense of safety, very common during the pandemic, and some psychiatric disorders. So depression, for example, but also PTSD, which is quite common after disasters, anxiety, or complex grief, for example. To all these type of impacts, I also added the amplification of mental health disparities, because we don't have to forget that we saw at the beginning the treatment gap. And so social factors also influence some inequalities in mental health conditions, both in terms of prevalence, but especially in terms of access to mental health care services, access to medications. And so the pandemic impacting more poorer people or people who are already marginalized and vulnerable with precarious working conditions, in parallel also impacted more in terms of mental health on these groups and these categories. And there can also be a worsening of pre-existing conditions. So if we think about, as I mentioned earlier, people with pre-existing anxiety or people with some other conditions, these might be deteriorated, amplified, or can worsen after a disaster or after the pandemic. And in general, as I was stressing right now and until now, we can distinguish different problems when it comes to disasters. So problems of social nature and problems of psychological nature. And we can distinguish three types of impact of problems. So pre-emergency social problems, emergency-induced social problems, and humanitarian aid-induced social problems. So if we think about the pre-emergency ones, we can have extreme poverty or marginalization, which are already existing social problems, which then are also amplified and impacted by the emergency-induced social problems. And examples can be the disruption of social infrastructures. And then we can also have humanitarian aid-induced problems. So those problems that are influenced by the humanitarian aid that is produced in this context to respond to a certain disaster, for example. In terms of social problems, we can have the undermining community structure, loss of dignity of a certain population, etc. And we also have problems of psychological nature. And also here we can have pre-emergency, emergency-induced, and humanitarian aid-induced problems. So for the pre-emergency ones, we can have severe mental health disorders and alcohol abuse, which is already pre-existing in certain communities for certain individuals, etc., which are then impacted by, in turn, by emergency-induced problems. We can have grief, PTSD, which is post-traumatic stress disorder, anxiety, etc. And then we have the humanitarian aid-induced problems. So, for example, in terms of psychological problems, it can be anxiety about the lack of information on food distribution, as an example. So these are all the sort of problems we can have in terms of social and psychological problems during a disaster or a public health emergency. I mentioned, and I'm talking about the pandemic as an example, because it's something that we all know very well, but I just wanted to tell that all disasters have an impact on mental health. And we can see like a similar pattern for the suicide rate of other disasters caused by natural hazards, such as hurricanes or earthquakes. And in general, I used to show this picture because I like very much to think about this path when I think about the impact of disasters on mental health. And in general, this type of diagram, this type of graph can be interpreted both in light of individual pathway throughout the mental health impact of a disaster, but as well as a community pathway or a country pathway. And this sort of explains in a visual way the impact of disasters on mental health. So I would like to follow all the diagram right now, step by step, just to explain to you why I think it's useful to visualize this diagram. So let's say that this is the red line is the mental health of, let's say, a community, even though, and I'm also curious then to know if you can relate with that, thinking about your own community, your own like family, your own country context, or you as an individual. So we have some pre-disaster phase. So here the disaster has not happened yet. And we have some warning and some threats that cause some like slightly, some peaks of, let's say, stress. I wouldn't say mental health conditions yet. Then we have the impact of the disaster. As you can see, the impact of the disaster has a negative impact on mental health. The mental health decreased a little bit, but it seems a paradox, but there's a phase, there's a moment after the impact of the disaster where there's a heroic phase, or that culminates with a honeymoon stage. And this phase sees a positive impact on mental health, which is characterized by community cohesion and that feeling of strength and cohesion and the willingness and every attempt to overcome the disaster, which is like indeed cohesion, I would say. After the peak, so the honeymoon, there's a sharp decrease of the well-being of certain community or population. And we can call a disillusionment phase, which is characterized by some triggering events, which can make mental health to deteriorate again. And then there's a higher peak and then it deteriorates again, etc., etc. So this is the disillusionment phase, which is the phase that follows a certain disaster, that follows this honeymoon of positive peak. And then there's the anniversary of the reaction, which is again negative, but then every other part we can define a reconstruction phase, like a new beginning, where there's a very slow reconstruction and recovery with some setbacks, but overall we can call it like a walking through grief. So it's again an improvement of the community well-being. So this sort of graphs exemplifies the impact of a disaster, of an important shock on a community. The length in terms of time can depend, but overall we can see this pattern. And in terms of diagram, in terms of framework, this can be very helpful to understand a certain community going through a disaster. At least it can help to understand the phases in which they are, or how to conceptualize the impact they have experienced from a certain disaster. Very important, a disaster impacts mental health, but not in an equal way, but in an unequal way. So the impact of disasters on mental health depend on interacting biopsychosocial factors, which influence whether people develop psychological problems or exhibit resilience in face of adversity. However, there are some factors that are deemed to contribute to differences in the impact of a disaster on mental health. This can be the prior exposure to a disaster, which can have both positive and negative impact on mental health. In terms of positive, because it means that a community might already be more prepared, and so more resilient, let's say, to a disaster, because it has an experience of disasters, and so it's more resilient, let's say. But it can also have a negative impact if we think about a new disaster that is causing, again, trauma because of a past disaster that has been experienced by that community. Same as other factors such as pre-existing socioeconomic resource disparities, so already existing inequalities. Of course, a country with a wide resource gaps can be impacted more in terms of mental health. Religious and cultural beliefs about the meaning of the disaster can help a lot interpreting the impact of a disaster and then recovering from a disaster, let's say. Trust in government institutions, also here we can see like a positive and negative impact, but of course it has an impact on the way and the extent disaster impact or not impact certain communities, and while others are more impacted. But also prior experiences with national or international government intervention and presence of litigation. So these are all factors that might discriminate whether a community, a country, a group of people experience more or less mental health impacts from a disaster. However, overall, we can have some groups that technically tend to be vulnerable for mental health disorders during a disaster. So even though this depends on many factors, certain groups are considered more vulnerable than others. And we can distinguish women, for example, pregnant women or mothers, men, especially those unemployed, those at risk of detention, children and the elderly, people living in extreme poverty, refugees or irregular migrants, people who experience trauma, for example, the death of a loved one or a close one, people with pre-existing mental disorders, people in institutions, and frontline healthcare workers. So you know well that especially for frontline healthcare workers, there have been many studies showing a deterioration of their mental health conditions during, for example, the pandemic, or in general, first responders, let's say. Disasters not only impact mental health directly, so via an increase of mental health conditions in people, but also by impacting the access to psychiatric medications because of, for example, of supply chain disruptions and the absence of stockpiles mental health drugs. You see on the right some WHO, I think, graphs about the access to mental health services during COVID. So for mental health medications, for like a huge percentage of people, there has been a delay or disruption in the access of mental health medications. Same for psychological and psychosocial support for certain groups. However, in contrast, or like interestingly, disasters may also lead to an increase in prescription of psychotropic medications and mental health drugs. So this is also another indirect impact of disasters on mental health. And so there are studies showing that if a community is much impacted by a disaster, it has been shown an increase in prescriptions and consumptions of psychotropic medications or mental health drugs in certain communities.
Sorry to interrupt you, just one question.
Yes.
Is this increase correlated with the number of people affected? Because then it could be explained, like in a disaster, you have more people affected, therefore more medication is prescribed.
Not always. Sometimes it has been shown that there are these increases in prescriptions, which are also unjustified, or I don't want to say that, but sometimes it can also be sort of an exploitation or taking advantage of the situation for certain pharmaceutical companies, for example, to increase the number of prescriptions in certain cases because of very, very distressed communities, which might start taking, for example, these type of medications. However, if I'm not wrong, trends show that after this sudden increase for the peak of a disaster where, for example, antidepressant or like some sort of other psychotropic drug might be consumed, in the longer term, then there's no continuation of in uptake of this type of medication. So usually it's like a peak of consumption, which then decrease and tends to come back to a normal rate, let's say.
Thank you very much.
So do you guys have any other question until now? Otherwise, I will move so I think I will move, and then if you have questions, you ask at the end, because the second part of this lecture, I think it's also the one that might be more interesting also for you, which is about the response and what to do. And that's why I wanted to present to you these guidelines, which are the core guidelines that you might need to follow when it comes to mental health and psychosocial support in emergency settings. So these are the guidelines of the Interagency Standing Committee, and even though they were published back in 2007, they are still the #1 document that people tend to look at when there's a disaster or like an emergency and we need to provide mental health support. So what's the aim? What's the goal of these guidelines? Is to enable humanitarian actors to plan, establish, and coordinate a set of minimum multi-sectoral response to protect and improve people's mental health and psychosocial well-being in the midst of an emergency. These guidelines have been written for low and middle income countries, but they also apply to high income countries for large scale emergencies, for example, or in case when some sort of document is needed to coordinate like a large disaster in terms of mental health and psychosocial well-being. And what's the audience of these guidelines? Very different and broad audience with very different actors, humanitarian actors, including community-based organizations, government authorities, UN, so United Nations, NGOs, and donors. Why such a broad audience? Because it's very important to understand that the type of response that is conceptualized in these guidelines cannot be performed by a single community or a single agency, but it is expected that these guidelines expect coordination among different actors to provide the best response, the best support possible. So it should be a combination of capacities to provide this support. And therefore it addresses several actors and several stakeholders. So what are the pillars of these guidelines? So the main concepts on which these guidelines is based. So human rights and equity, participation, do no harm, building on available resources and capacities, integrated support system, and multi-layered support. I will quickly show what multi-layered support means I'm sure many of you have already encountered this pyramid with all the multi-layered support. I will not dive into all the different strata directly, but I wanted to show you a video. Then if it doesn't, if you can't hear it properly, I will explain you in words. But first, I would like to try to show you this video, which explains very clearly these concepts. So the conceptual basis of these guidelines. So I will try, please let me know if you can see here. Too high volume? So can you see, first of all?
Yeah, we can see.
You can see. So now I will just skip the, okay, tell me if the volume also is fine.
No one who experiences
It's okay.
Good.
Fine?
Yeah, it's good.
Okay.
disaster is left untouched by it. A key priority during crises is to protect and provide for people's mental health and psychosocial well-being. Every individual will experience the same event in a different way and have a different capacity to cope. The nature and scale of the disaster or conflict will, of course, be huge factors, but also, for example, whether the person has pre-existing psychological conditions and vulnerabilities. Age is another crucial factor. A child's physical, emotional, and social development plays a key role in their experience of an event, with adversity having a direct impact on their daily lives. Because of this, humanitarian workers need to be alert to the environment, namely who is not recovering and what specific support they need. The core principles for interventions are: 1. The promotion and protection of an individual's human rights and dignity. 2. Encourage those well enough, including children and youth of appropriate age, to participate in relief efforts. 3. Avoid potential risks such as encouraging dependency. Remember, do no harm. 4. Take advantage of available resources and the capacity for self-help. 5. Provide integrated support systems instead of standalone services. 6. Use a multi-layered support structure. This means advocating for basic services which are safe, socially appropriate, and protect dignity. Activating social networks and engaging the individual's family where possible to provide supportive, child-friendly spaces. Providing basic support services with no specialized content for a specific target group. This requires looking out for children with basic and urgent needs, listening to a child's concerns and calming those in distress, linking children with the social support and services they require. A fourth layer includes offering access to specialized clinical support from mental health practitioners where needed. In the immediate aftermath of a disaster, it is also important to address social considerations, such as providing simple, sensitive, reliable information, supporting family tracing and reunification, involving communities in the design and re-establishment of religious, social, and community facilities, allowing time for culturally appropriate ceremonies and funerals, providing appropriate activities for children, resuming education and engaging communities. You can also make an immediate difference in the facilitation of psychosocial provisions. For example, ensuring that children and adults with serious mental health conditions are referred to the appropriate services, working with the existing healthcare system and assisting with the provision of drugs and treatments, supporting those with emotional stress through listening and compassion, and providing training and promoting non-intrusive community-based emotional support. As you see, there is a lot you can offer. So let's work together to help those in need of psychosocial support, encourage the correct treatment, and make sure that your response is always relevant to the individual you're helping. For more information.
So You have seen that the video explained quite well all the different main concepts, first of all, and all the process, the multi-layered support provided by these guidelines, which is the aim, the nature, the center, the main pillar of all these guidelines. So first, the social considerations in basic services and securities, the attention to the social factors, moving then on to strengthening of community and family supports, for example, supportive child-friendly spaces that was mentioned, until we have the non-specialized support, among which, for example, we find like what we call a psychological first aid, for example, those of primary healthcare doctors, physicians, and then we have a more specialized services, which, however, it's the top of the entire pyramid. So if we want to focus then now more on this non-specialized support. As I mentioned, psychological first aid, I encourage also you to check the WHO document about psychological first aid if you're interested. This type of aid describes a humane, supportive response to a fellow human being who is suffering and who may need support. And different components make up the psychological first aid, such as, for example, providing practical care and support, which does not intrude, assessing needs and concerns of people, helping people to address basic needs, for example, food and water, provision of information, listening to people but not pressuring them to talk. So listening-based interventions are very common. For example, in terms of listening, if we refer to, for example, the COVID-19 pandemic, many phone line-based support were provided either for healthcare workers, for people who were infected, especially at the beginning. And it's in terms of a more like non-specialized support, many times where volunteers or like residents or undergraduates, let's say. Also comforting people and helping them to feel calm, helping people connect to information, services, and social supports, protecting people from further harm. So these are sort of the components of these type of support that I wanted to explain you a bit more in depth. And then the others are very basic, like specialized services, psychiatrists or mental health professionals specialized, while the others are more like social needs and psychosocial services, strengthening of community and basic needs. I wanted now to show you how these guidelines look like inside, like how the document, what's this document, how does it look like? So when you open the document, it's very straightforward, it's used, but I think it's important also for you to know where to look for the specific information. Otherwise, it seems that it's this very vague concept of these guidelines you will never open because you think it's too complicated. Instead, it's very easy to use. So it's divided per columns, and you find very interesting and important information that can guide not only like the mental health response, but also any of your research or things you might be interested in the future. You have some functional domains, which are the main topics that are addressed by the guidelines. So you see, in this case, you have coordination, assessment, monitoring and evaluation, protection and human rights standards, which are the main topics, let's say. You are interested into coordination, you go to the first theme 1. What do you have in the second column? In the second column, you have emergency preparedness factors. What does it mean? It means that these are all the factors that you need to implement for preparedness. So if you are in a country, if you are well before in advance, if you want to make sure this country is prepared in terms of mental health and psychosocial well-being, then you look at this column. However, if you are an organization, if you are working in a country, or you are international organization, you are called to respond in the moment. So you are not there and you need to respond promptly. Then you won't look at the emergency preparedness column, but you will directly look at the minimum response column. So in this gray column, you find out all the minimum responses. So as soon as they call, what you suddenly need to implement, divided per topic, of course. So let's say I'm interested in coordination, minimum response. So I've been called, I need to respond right now. First thing to do, establish coordination of intersectoral mental health and psychological support. So that's exactly what I have to do at the beginning in terms of coordination. And then I have a fourth column, which is about comprehensive response. And here you find all the more comprehensive actions that you need to perform. So once you understand what's the minimum you have to do, then if you have more time, resources, capacities, then you can look at the other column for a comprehensive response. So how to then respond promptly, for example, after the minimum response that you do at the beginning. In this case, just an example, develop sustainable coordination structures, including government and civil society stakeholders, but also develop interagency strategic plans and promote joint mental health and psychosocial support programming and fundraising. So this is for a more comprehensive, long-term, broader response structure. If you go on with the guidelines, you find in chapter 3, the action sheets for minimum response. What does it mean? You want to do a minimum response, then you can deepen each minimum response action. As you can see here, you have here the topics, the same that you found here in this column. So you find here all the topics. We've just listed all the minimum responses. So in this column, you find what is in gray here. So in this case, you see established coordination of intersectoral mental health and psychosocial support. So here you have a summary. So you know per topic, all the minimum responses that need to be done, divided for macro domain, let's say. And if you go on, for every type of action, you find an action sheet. For example, this is initiate participatory systems for monitoring and evaluation. And what do you find for each action? Some background information. You see, it's not extensive. You can read immediately. You need to do like a prompt response. You can read. It's accessible. It's understandable. It's not too long. You have some background information. You have the key actions with the different explanations, very specific, like collecting data on indicators in the midst of emergencies, provides baseline information, etc. So you have all the different actions. Then you have some key resources in case you want to deepen some specific topics with a link directly you can access very easily. You have some smart process indicators, and then you have an example. So some case studies that explain to you where to look at for similar experiences, what are the lessons learned and what you can access. So you can have like a proper idea. As you can see, it's very easy, very straightforward. I feel it's a very important resource. If you're interested in this topic, I advise you to briefly check these documents. And this is not the only document. You can also find a support assessment guide. So this is especially used to to check and to perform a mental health assessment after a disaster. So what are the needs? What's the, to perform a comprehensive assessment. And also here, it's very practical, very handy. You can also have a look. These are the type of tools and documentation you will find inside these guides. So you actually find a template. So a template for desk review of pre-existing information relevant to mental health and psychosocial support in the region or in the country. You actually have a template with all the information needed. So all the different information you will need for this rapid review to understand the state of the art of the mental health conditions in a certain community. But you also have some data to be collected through interviews with cultural and medical experts, social anthropologists, etc. So these are the necessary information that you need to do such an assessment. So as you can see, it's very practical, and I think this can be very useful as a starting point, at least if you're interested. So this is it, and I also saw that we still have some minutes for some questions, which I'm very happy that we still have. So if you have some questions on the slides and everything, just feel free to ask. So I will open again on the references. Anyway, you find everything in the references, and I should have shared also the main documents with the organizers of the course. So you will find also these guidelines and all the documents in PDF in case you're interested. So I give you some space if you have some specific questions. Otherwise, I will give the floor again to Georgia and then to Marcello.
Can I ask a question?
Please.
So if Okay, I'm just asking about the level of knowledge of like psychology and psychiatry in general you have to have or you don't have in order to provide like psychological help to victims of a disaster in general.
So it comes again back to, now I can't move with the arrows. So it comes again back to the pyramid of the different types of support. So it depends on the type of support you are providing. For example, I'm not a psychologist or a psychiatrist, I'm not even a medical doctor, and therefore there's some type of support I would not be able to provide. But let's say I'm a global health researcher or cultural mediator or volunteer working for an association or social worker. There are some types of non-specialized support. Then in an emergency, not for specialized services, let's say, I can provide still as a first impact, first support, at least to guarantee all those type of psychosocial services, psychosocial well-being, to, let's say, to minimize the mental health impact of a disaster. Already offering some listening-based support, important information. There are several methodologies also for different types and strategies for support. But in general, avoiding, for example, worse consequences on people affected by disasters, notifying to psychologists, authorities, medical doctors, those cases that might be at risk, for example, so those more critical cases that might need a specialized support, that's already some support. And therefore, you don't have to be a psychiatrist, for example. Of course, when we talk about specialized services, when we talk about a more structural support, when we talk about the more comprehensive support or long-term recovery for important interventions in terms of mental health, of course, some, psychologists or like people with a specialization can provide much more support.
Thank you for your answer.
In terms of, I can speak about in terms of global health researcher, and I can tell that, for example, the baseline of this pyramid, it's something that it's much neglected when we think about interventions in terms of mental health. These basic needs, they're missing. Sometimes this is very neglected, and sometimes this is what people need immediately, and these might help avoiding worsening of many psychological conditions, the safety and security soon after a disaster, provision of basic services. Yeah.
Are there any other questions for Martina?
Otherwise, I'm sure that in the following section, we will have, with my colleague Marcello, you will have much more insights into the practice of providing mental health on the field. So probably you will also, if you have some questions or doubts, this will be solved in the following session, I'm sure.
As I'm aware, Marcello is not here yet.
I saw him.
His session.
Okay.
Yeah, I also saw him, but now he's not among the participants.
Okay.
If I'm wrong, please correct me, Marcello. But either way, his session is supposed to start in half an hour from now. So I would like to thank you very much, Martina. If there are any other questions, I will forward them to you. And then at 4:30, so in half an hour from now, Marcello's session will start. And after the Marcello session, there will be the second group presentation of TDMT. So thank you once again, Martina, and see you all in 30 minutes.
Hello. Hello, guys. Is yours, okay? You can start.
Okay, so hello everyone. My name is Marcelo. I'm a clinical psychologist as a background, so I work as a humanitarian mental health professional on the last 20 years. Work in the different context, work in the different organization. And nowadays, I'm the mental health and psychosocial advisor for International Committee of Red Cross in Middle East, based in Lebanon. So thank you for the invitation, the colleagues of Crimidine. So it's very good to have the opportunity to share and to have this opportunity of exchange. And then also, I want to ask you, if you don't want to open the camera, open your mic on the moments that you have doubts, questions, something to contribute anytime, so you can try to make this as much interactive as possible. Okay, so let's me share, or Farman, you're gonna share, or should I share myself?
You can share.
Okay.
Yeah. But if you need some help, I'm here. So
okay,
just let me know.
Can you see my screen?
I can see, I think, because maybe they can also see.
Okay. So the idea is to making the link to the presentation of Martina. The idea is to try to dive in more practical aspects on the mental health and psychosocial supports in emergencies. I'm pretty much focused in the humanitarian settings, that it's a field that I work. So considering what you should take in account when you propose the mental health and psychosocial support in emergency settings, considering the humanitarian emergencies and special. Just to check, so I moved the slide. Can you see that? Anyone? Can you see the title of the second slide, Farman? Can you see that?
Yes, I can see, but the students needs to, participate. So it's like I was waiting for them.
Yeah. Okay. Perfect. Okay. So first, we think we need to consider that when you're talking about, and here the idea is not to general considerations or the main ideas or manuals or guidelines. So to think about practical aspects. So and the way that when we are in the field and we have something happen that could be related to the disaster, or it could be any kind of emergency, we need to ensure that we have also the mental health as part of the comprehensive humanitarian response. When you think about the emergency preparedness, we ensure that we have the mental health component on that. So, of course, when you think about the response, so it depends on the manufacturers. Some elements that come to the field. One, of course, the first, it's about the type of event. So, which kind of event we are talking about? It's an explosion, a blast, a bomb blast. It's a natural disaster as an earthquake or a mass car accident, a train accident. It's a conflict, terrorism attack, or as we recently our experience on the pandemic. So that it's would be essential to understand and to prepare the response, because when you think about the mental health, we're talking about to integrate that in the how to respond better, the consequence in terms of emotional reaction, acute distress reactions, the cognitive impact that could be related to the event. And we need to consider exactly what passed for the people's mind when they live such type of experience. So first, the type of event, it's very important. The second one, it's where it happens. So what is the context? What is the landscape that we have this event? That could be inside a big city as New York, Beirut, Madrid, and Nairobi. It's quite particular when you're talking about a big urban center, that if it's happened on the kind of busy market, one place that we can many people circulating in that, so it's the countryside, it's the rural area, or it's happen on the scope, on the scene of ongoing conflict. So that would be also be essential to define which type of response we choose and how you can implement that. The other element is the length of the crisis. So we're talking about one event that could be one explosion, or it could be something that can take some days or weeks or month. If you're talking about ongoing conflict, or if you're talking about, let's say, our earthquake that have some consequences also in the following days, or as we are experienced for the COVID pandemic, something that take years. That's not the first time. The Spanish flu, it was more or less the same length, but we need to also take this in consideration when you think about the overall response and when you think about the mental health. Of course, that it's also connected to the overall response capacity, considering where it takes place and the length of the crisis and the existing capacity to respond to that. So we're talking about the existing health system, the infrastructure, the capabilities or the expertise existing on the human resource, and other contexts, that's all other factors that can influence how you can set the response. And also, who are the main targets? So we're talking about the general population, civilians, you're talking about military people, you're talking about army actors. There is one specific target group. For example, if you think about one incident that happened in school, or any other kind of, let's say, institution, and we need to consider exactly who are the affected group, the affected population, to think and to be prepared to respond sometimes to the specific needs. So when you think about emergency, could be a bit repetition, but just to understand, when you're talking about emergency and the humanitarian situation, you're talking about the significantly change, the complex and the the urgent needs. Consider that sometimes you're talking about in the context that you already have some previous incidents that you, for example, refer to the armed conflict. But also we need to consider that in terms of the capacity that exists in the ground to cope with the crisis, and that it's a part that it's very important, and we back to this later when you're talking about specifically for the mental health. We're talking about not only the response that we can do, but how we can increase the coping capacity or the resilience of the people to deal with that. So we are all the time talking about the response to be balanced according to how we can give people the capacity to deal with that, considering the individual coping, but also the collective, the resilience of the systems. So Martina already passed through that, but just not spend a lot of time, but just to mention about this specific reaction. So when you're talking about the mental health reactions or the mental health issues connected to a disaster or other type of emergency, we can categorize according to that. So we're talking about emotional reactions that could be as a kind of normal reaction to a kind of unprecedented situation. We're talking about the impact of the cognition of people. So the issues of being confused or problems to be concentrated and to have the problem to keep the attention. Physical reactions. Sometimes we can identify the mental health issues not for what the people complain about the emotional reactions, but for the physical reactions, talking about the somatic symptoms. I have came to my mind some flash of experience that we can go in some context and talking in special with the hospital and the hospital teams and also in the primary healthcare. And they mentioned that the people not complain about the psychological distress. They don't use this kind of words, but they can observe the increase of somatic complaints, medical complaints in relation to the stress that the people are passed through. So when you, I remember there was an experience that you work on the PHC, and they start to discuss with the doctor, say, but something it's happened here. You're talking about one area that's affected by by huge violence, and they say, but I think the people are cope with that, so the people know how to deal with that. And when you start to do try to review the medical files and try to see what's happened in terms of the profile of the medical complaints after events, there are a lot of increase in terms of hypertension cases, people with somatic complaints, problems of sleeping, and at that time it's not, even the people cannot connect that to the experience that they are dealing with. So that sometimes the physical reaction, the somatic symptoms are a very important entry point to understand the mental health issues. And of course, the impact on the personal reactions. So how it's the capacity of the person to be integrated into the family, in their community. And we can see one kind of breaking down of this social functionality when the people are experiencing psychological distress in relation to the acute distress. So the main thing, and it's probably the most important thing, it's not to know by heart all this list of symptoms, but to understand exactly what they means in terms of acute stress reaction. And also to understand that they are normal response to a normal situation. So to have the acute distress reaction, don't make anyone a mental health patient. Make them as a normal people, because normal people react as with acute distress when they pass through a normal situation. That it's completely natural, and we can expect that most of the people are experiencing somehow this type of reaction for a certain period of time. We go more in details about this periodicity and the persistence of the symptoms that you can consider for different diagnosis or their understanding of the mental health issues, but you need to consider the acute distress reaction as a normal response. And what means a transition, it's a transient disorder that develops in the individual without any other apparent mental disorder in response to exceptional physical and mental stress. So it means that all the people that have not, let's say, a history of mental disorder, they even they are passed by this type of reaction, and that it's a normal reaction. If the person has a previous history, it could be something different. We need to pay more attention. We need to considering on the also in the medical history. But from acute stress reaction, there is a certain level of reaction that we should consider as a normal reaction. In that sense, we can also, in the, let's say, very simple way to summarize the clinical understanding or the clinical thinking about the acute distress reaction that can come from the events for the acute stress reaction. Again, that's a normal reaction. It's sometimes after some days and weeks, it can be configured as acute distress disorder. So in that sense, we're talking about already about a disorder that is not the person cannot deal with after first 1 or 2 weeks. So, and after that, we can have another situation that could be adjustment disorder or PTSD that are quite similar in terms of symptoms. Again, the main difference between them, it's the persistence of the symptoms. So the adjustment disorder can go to 1 to 3 months, and after that, we can think about the post-traumatic stress disorder. But just to understand that for those people that experience acute stress reaction, only 5 to 15%, according to the literature, go to develop a more severe mental disorder. That in this case, we need to be followed by a mental health professional. I saw that Martina also passed through. The idea here is just to understand how could be this emotion high and low mood, considering the different phase of disaster. Consider the periodicity when you have, can come from the warning, the threat of the pre-disaster, let's say, for some things that could be predicted. And we have the impact, the moment of the event. And the first reaction, it's very positive community mobilization or individual mobilization to support. And this is a reaction to quickly overcome with the event. It's a normal reaction and also very useful, because this heroic reaction can be also very important to create the community cohesion and to support each other. But we have to understand that also this reaction, it's natural as our capacity of a human being to provide support to each other, but also should be understood as a way to quickly deal with something that I cannot deal with. And it's normal that after that, the acute phase, we can try to have the, let's say, the low emotions and the low moods, that because we don't are involved, we are not involved that that much in the response, and we start to realize and we start to elaborate the importance, the severity of what we lived, and it's normal to have this increase of sadness. We can observe more symptoms. Again, it's normal reaction. So we're talking about this change of mood, the change of reaction that is absolutely normal for all the people that experience that, for those that are affected, but also for those that are directly as first responders. And then we can have this recovery, the real recovery, when the people start to understand and try to look at the future and try to build perspectives and try to adapt to the new reality. So of course, this is not a linear way. So we can have this up and downs, and special when you have this, when you call special moments. That could be the anniversary of the event, when we have a kind of memory, or for those loved ones, and also the properties, or any kind of impact that you suffer from that. So this is normal that we can have this up and down on the mood, but after that, the idea it's most of the people can come to a real recovery. So that it's the pyramid. So when you have the layers of the support, and now we are here moving from the understanding of the issue and try to understand the response. So the different levels of the different layers, as you said, for the response. That can be for the basic service or the basic psychosocial support integrated to the basic service. We can have a focal psychosocial support that we can have activities that you are doing collectively, could be on the community space, but already thinking about how you can support this community cohesion. The word psychosocial means exactly that. So what could be the connection of psychological well-being with social interaction, with the social dynamics, how you can make the family support each other, how you can see, make the communities to understand the most vulnerable people, how you can try to set a specific response or specific activities for certain target groups. The higher level, it's more the psychological support. So we are trying to move that for the more basic to the more specialized. That can be involved already a training of no mental health teams to provide basic mental health support. So here we're talking about training professionals in the hospital, primary healthcare staff, to how they can include the mental health in their practice. And the higher level is the specialized mental health. So we're talking about the work done primarily by clinical psychologists and psychiatrists thinking about the cases. That specialized mental health care on this sense that goes more on the disorder level. Remember the previous slide that talking about the different levels, the different, let's say, course of severity. So the specialized mental health go more, let's say, in the more severe forms of trauma disorders. Now I would like to go on this two field experience. I propose for us to watch that, and we can discuss a bit about this two experience. Farman, I'm not sure if I can, if it works if I do for here, because last time it was a bit annoying, or if you can do on your side, so I can try.
Okay, so let me try. So I should run the first link.
Yes, please.
Okay, okay. But how do I get the link?
No, okay. Let me do on my side.
Okay,
And
please try.
and let's see if it works. So that is the first one. Just let me know if it's you can see and listen. Yes.
I can see the link. I can't.
The video.
The video cannot see the video.
No.
Okay. Farman, you cannot see the video.
No.
Okay.
Wait, let me try with the multiple trans.
So if you want, I can.
Please send me in the chat so I can.
Okay. Okay, so I can.
Okay, I can wait. I can do it. You try now. Now, try. As I change some settings with this advanced sharing option, it should be all participants. So you can also.
So that is the link I send you in the chat.
Yeah,
so.
you just try once and let's see. Are you trying to click?
Yes, I'm trying to click and see if now it's. Can you see that?
Not yet. So.
Can you see?
No.
No.
But I can. Let me try.
Sorry for that. That's why I send the link earlier to you.
Okay, so I will share my screen. It's the first one, okay?
Yes.
Okay.
Yes, we can see that.
Yeah.
I can see at
least. Can I run it?
Yes. But I cannot listen. There is not.
Sorry.
Yeah, sorry. Is that supposed to be sound? We can't hear anything.
Yeah, I cannot hear. I cannot hear anything as well.
You cannot hear.
No.
Okay. Why not? It should be. Wait. But can you see the screen?
Yeah. Yes, your screen we can see.
Is it because of the? Oh no.
I can try again. If you stop to share, I can try again. Let's see.
I think that you have to active the sound that like share the sound. There's some option that it's share sound.
Wait, external head. Okay, maybe I'm.
In emergencies with economic statistics.
Is it audible?
Rates. Around 200,000 people have been killed.
Yes, now we can listen, I think.
Marcelo?
Yes, you can just shoot back to the beginning, because I think we can listen from your speakers, but I think it's we can follow because there is subtitles, so it's fine. Yeah, thank you.
Today, more than 160 million people need humanitarian assistance because of conflicts, natural disasters, and other emergencies. The media often measures humanitarian emergencies with economic statistics or mortality rates.
Around 200,000 people have been killed.
But the rates of mental disorders can more than double in humanitarian crises. 1 in 5 people affected by conflict are estimated to have a mental health condition. And in emergency settings, the economic, social, and health impacts of these conditions are extremely high. That's why it's crucial to increase mental health and psychosocial support in the wake of humanitarian crises. Many humanitarian agencies and organizations respond to emergencies across the world. Working in health facilities and through community networks, these organizations improve and expand mental health and psychosocial support services in dozens of countries like Ukraine, South Sudan, Syria, Nigeria, Yemen, Somalia, Bangladesh, and many others. For example, when the Syrian conflict began in 2011, many health professionals fled to escape the war, and 23 million Syrians were left with little to no mental health care. In response to this emergency, more than 500 healthcare professionals have been trained to provide care for people with mental, neurological, and substance use disorders. Thanks to trainings like these, free mental health and psychosocial support is now offered in more than 130 general healthcare centers, social care facilities, and educational programs in 10 cities across Syria. In comparison, in 2011, these services were based in just 2 psychiatric hospitals in Aleppo and Damascus. Samar is 47. She lost a son during the conflict and was forced to move to Deir Hassan camp with her family.
صار معنا نزوح كتير وصار معي تعب كتير وتراكمت الأمور علينا. كتير تعبت كتير ولحتى حسيت إنه يعني صرت أنخنق، صار قلبي عندي تسرع بالقلب.
Samar was referred to a primary healthcare clinic with mental health service in the camp. There she was assessed by a psychosocial support worker and a doctor.
نظرة قاتمة تجاه المستقبل، شعور بالحزن الدائم، شعور بالكآبة المستمرة تجاه الحال اللي كيف كان وكيف صار خلال سنوات الحرب الطويلة يعني.
وأعطوني دواء وبعدين صرت أعمل جلسات عند الأنسي وردي، التنفس هيك بطيء، الاسترخاء، يعني هيك نصائح كثير ريحتني.
المريضة بعد عدة جلسات حسينا بثمار، حتى هي كمان هي صارت إنسان ثاني، صارت تهتم بحالها.
Samar also started taking better care of her home, her family, and began to interact with the outside world once more.
والحمد لله تغيرت حياتي، هلقتين بضحك بطلع بفوت بمشي.
Samar is one of over 4 million Syrians who now have access to care because of programs that integrate mental health care in primary care settings, like WHO's MHGAP program. It's a remarkable achievement, but there is much more that needs to be done. Through a further expansion of these services in Syria and around the world, we can continue to improve people's mental health in humanitarian emergencies.
Okay, thank you. Thank you for
any other video?
Let's see if you have questions or comments about this video before we move to another one. So there is anything special that caught your attention on that? So there is anything that's what's your perception about the work done, the work of the primary health care? So, or any question that you would have about that?
Well, for example, I think that there's a big problem, mental health after a disaster, because, for example, in my country, in Panama, we have a lot of natural disaster. We have like very river that destroys all other stuff, and after I think government or the or for example, the hospitals or the primary care centers don't have a lot of importance in the mental health of the people that suffer a disaster. So I think that it will be better, or we have to make more policy, or I don't know, more. We have to take importance in this topic. I think that that's a good, an interesting topic for example, in my country.
Yes, definitively, Victor. I don't know in details in Panama, but it's overall the situation in Americas. When you see considering and special in certain region that you have the natural disaster that's happening almost every year, and also for many different type of events. And it's you're completely right. So we need to invest more, but I have to say that when you look about the health policies on the, let's say, the last years, the integration of mental health as a health response, it's something still very, very new. And in terms of policies, could be more advanced, because I think in special WHO is working a lot on that direction. But when you look about the real implementation in the field, you're right. So it's very, very limited. Just for you to have one idea, when you look about the national health budgets in general, when you take the average budget for the whole countries, only 2% of the health budgets, they are dedicated to mental health. I'm not talking about only mental health for response to the emergency. I'm talking about the whole mental health sector, included just 2% of the national health budget as on average. And when you look about this, how it spends, this 2%, most of them, they're for the psychiatric hospitals, psychiatric institutions, where they have the people that stay there for a quite long time. There is also the huge force to change the policy, to change the mentality of providing mental health for severe mental disorders, but it's still that it's spend a lot of, let's say, most of the health budget dedicated to mental health. Thanks for your point. It's really important. Any other comments or question? No? Maybe you can move to the second video, Farman. So now you are quite professional on that. So let's see if it works on the second one, and you can see that experience too.
Just send it to me and I will.
Okay. So this is this one.
أنا في السجن حاسس حالي.
Can you see the screen?
Yes, I can see.
مسكت الجزاز كله كسرته. قعدت 97 يوم، عملوا لي حوالي 15 مسحة، يعني شفت الموت فيهم، انهارت وتعبت نفسيا، حاولت اني انتحر لاني انا وصلت مرحلة يأس واكتئاب نفسي، وما بكل مرة بيقولوا لي بوزيتيف بوزيتيف بوزيتيف. اجاني اتصال على جوالي اكثر من مرة، بيجي 6 مرات، وكانت نفسيتي تعبانة ما رضيتش ارد عليه ولا بعرف الرقم. فطلعوا مسؤولين الصحة النفسية
يوم ما بنساه، كان مرهق جدا
ضاغط جدا وشعرت يعني بالتعب النفسي فيه.
قال لي أنا معاكي من الصحة النفسية، وكان يتابعني ودايما يرن علي، فدعمني نفسي وريح نفسيتي. كنت أظل أرن على الرقم هذا المتاح فيستجيب لي ويرد علي.
47 هو كان أكثر رقم اتصالات يعني استقبلناه واتصلنا عليهم في يوم واحد. لما بتشعر إنك بتساعد شخص أو بتوعيه بمشاعره أو بتخليه يستوعب الحدث اللي هو فيه أو يخف عنده مستوى الضغط النفسي أو التنمر المجتمعي تجاه الإصابة، بكون بشعر بسعادة. يعني كل الضغط النفسي والتعب تقريبا يتلاشى مقابل كلمتين ثلاثة من هؤلاء الأشخاص اللي بتعامل معهم.
له ألف شكر إني أنا وصلت المرحلة اللي وصلتها وطلعت من الحجر ومتعافية وكويس.
Thank you, Farman.
Yeah.
Thank you.
Can I stop now?
Yes.
Okay, so I think now we can continue.
Yes. So comments, questions, your perception about this second. I'd like to know from you what's the main difference that you see between them. The two experience. The first, that integrated mental health and primary health care, and the second one, it's the psychological, they call psychological hotlines, the support over the phone during the pandemic. What's the main difference between them and your perceptions? Anyone? Farman, anything from you?
Well, I think it's a very important topic. I mean, it's like I think people in some parts of the world, they shy away in discussing mental health. They don't even consider mental issues as health issues. They think like some are cultural reasons, some say like other socioeconomic situations. So discussing mental health like at a grand scale will, I mean, like you guys are doing, is helping people. Like imagine living in a conflict situation. So yeah, it's very important.
Yes, try to work to do our best on that. Any other comments?
I hope the students are alive, because I cannot hear from them.
Can I comment?
Yes, please.
Yes, please.
I'm from Palestine, so I'm very
Okay.
familiar with the mental health situation in Gaza. Not only regarding COVID, but Gaza is one of the most places in the world where I've heard like insane numbers of the amount of mental health people who are mentally affected by, just in general, the wars that have happened and the bombings, and a large number is children. So I think having this hotline or having just mental support is especially because in the Middle East, mental health is kind of a taboo topic, and it's people fear the stigma that comes with it. So having this private conversation on the phone with someone can be life-changing, as we saw in the video. So yeah, that's my comment.
Yeah, no, thank you, Natalie, for commenting that, and especially when you have your word from inside and knowing this experience, and that you're right. So with this experience talking about the COVID pandemic response, but we know that's the mental health issues for the things that you mentioned about the conflicts and the bombings and also the incidents that create or aggravated many mental issues, and especially when you think about children and some specific groups. So, and in that sense, on top of the existing problems during the pandemic, there was one additional issue that the people cannot go to the health facilities or cannot go to the mental health center because of the lockdowns or for those people's in quarantine. So that was an additional reason to have this the psychological support over the phone, as we call the hotline, because there is the period that they have this very strict quarantine, and even if you have people that could be prepared or health professional, mental health professional, they cannot go. So I'm saying that just to compare the both experience. So when you think about on setting the mental health response, we need to think about the event, the implication that you bring, and try to deliver a different type of aspects. For example, the first video, it's about the gap of access to basic mental health or the mental health care, because he said in the video, most of the psychiatrists and mental health professionals, they left the country and leave 23 million people without any kind of support or almost no mental health care inside the country. So the response it was to try to improve the capacity of the primary health cares to do the basic mental health, and at the same time to try to improve the investment on specialized mental health care. But in this case, that would go more in the psychological focus layer of the pyramid, and here more psychological focus intervention for the hotline to have the proper individual follow-up, not through the primary health care, but people, counselors, some of them they are psychologists that are involved in this project. So that raised the issue when there is not one specific model as a mental health response. So we need to frame, we need to define that according to the context, according to the needs, according to the reality that we see, and of course, according to the local capacity. So, yeah. Let's, if you don't have other comments, anyone want to comment anything in special, or you can move. Let's move then. Can you still see my screen?
Yeah.
Yes. Okay. Thank you. So when we look on the mental health response, there is a part of the work that is the preparedness. When you're talking about how you can better prepare the health staff for the mass casualty. So how you can integrate the mental health component on the mass casualty preparedness. So we see that when you're talking about preparedness, we have the MHPSS response that can take in the different levels, and we can start to work before the event, exactly the preparedness. We can have the work that take place on site at the moments of the event. We have the hospital phase, and you have the post, let's say, post casualty moment. So if you go in details, we see that we have these 4 steps, and all of these phases to have a comprehensive response, they need to be prepared, and that to be designed in advance to ensure that you have the minimum or the best possible capacity in the different levels of response. So talking about the preparedness planning phase, we need to be prepared. So this is what the colleague Victor mentioned before about how the health professional could be prepared or not to deal with when we have the emergency in terms of the mental health response. So there are some steps and there is some aspects to take into consideration on the design of the preparedness. One, so we need to have the clear view of what could be the formal or the not formal mental health or psychosocial service providers, what could be the local service, the local organization that can be identified and we can agree different types of protocols in terms of referral pathways or how to better collaborate and coordinate in case we need to have a joint response. Another point, it's about to build the capacity. So we need you cannot build the capacity on the moment that the event happened. We need to have this preparedness. We need to build the capacity of the first responders, the emergency teams to take into consideration what I have to do to consider the psychological basic support as part of my task, of my work, and to provide the relevant trainings for that. It's very important to have a mental health focal point. That's someone that can be a role of supervisor and coordinator in terms of emergency preparedness. And this person could exactly go through these different phases and try to guide the process in the moments that we have the event. We need to think in the moments that it's happened, what could be the lines of communication, how you can ensure that the teams are well informed, and special how they can define the flow of information when you consider about patients and talk to the families, and it can be reduce the stress for the first responders, but also for the families. And we need to think about the mechanism. So how you can identify, how you can contact the families, how you can involve those relevant people that need to be informed at the moments that the event happened. So when you go on the pre-hospital phase, I'm talking about on the moments that something happened on the community, and we need to mobilize and to deploy a team to go there. So we're talking about the acute intervention. So you're talking about the first hours of the incident. You're talking about the golden hour. And the thing is, the golden hour, it's the moment to save lives, but also an important to take a look how we can see those people that could be more in need on the mental health support, including the first responder, the teams that you're working on the emergency response. So people from the community, volunteers, professionals. So we go on the all emergency preparedness, and on this scenario, you should have a mental health professional that could be part of the team, to not to be the psychologist inside or each single, let's say, first responder team, but someone that can take a look on these aspects and they can support the first responders and how to deliver this issue. So the main objective on this phase, on the response on side, is to provide the basic psychological support, care and support, helping people and to address the basic needs. It's not the moment to do the therapy. It's the moment to use the simple tools, the basic tools to ensure that all the people, they are not only saving the bodies, but to save people. And connecting the different people that need to be informed and try to better connect people to the resource. And the second objective is support the first responders, talking about stress management and self-care, how we can at the same time take care of the victims, think about the psychological distress, considering the acute reaction as a normal reaction, but looking for those situations that need more, let's say, a proper individual approach and intervention, but also look at the teams. We know that from the scene of the pre-hospital, when you go for this type of event, it requires another understanding, another thinking for the teams involved. Because the paramedics, the teams that work in the hospital, when they go as a mass casualty response, they look not only at the individuals, but they need to look at the scene. So in the hospital, that enter one by one, the entire teams go to this patient, and they stabilize the patient, they do what they have to do, and they know what to do. But when you look at the scene of the mass casualty, we need to look at this individual, but at the same time, we need to look at the whole scene, because there is a risk that you enter in the building that is that's destroyed by a bomb, or to pass for any other type of casualty, and we take care of the first patient, and we even don't know what's happening inside. We don't know what the needs of the people inside. So these two perspectives in terms of care, of course, individually based, but the understanding, the thinking out the team that are deployed is to look at the scene and to understand and to do this visual and on the moment the triage, and to see how we can support those people that are more in need. And for the mental health, it's also important looking at that from the psychological perspective of the patients, but also to see how our first responders, they're behaving, how they are dealing on doing their job. So how they can communicate to each other, how they can manage their own stress on dealing with the stress of others, or dealing on saving lives. So it's very important that when you have the mental health focal point or the mental health professional that look at that. When you go to the hospital, that it's another scenario. So we're talking about patients that were referred to the hospital. Let's say this is more a knowing setting, because the health professional, they know the space, they know the context, they know the scene. But when you have this big number of cases arriving at the same time, so it's very important that we can looking on the dynamic of the team, and also to see what has happened, because at the same time that is happening, we have many things that are also happening out of the ER. And there is the families there are people looking for the information. You have the media, we have authorities, and we have a lot of pressure into the health team or people that come to looking for information. And of course, everybody's very surprised and very affected for what's happened. And it's very important to keep the people updated, what's happened, what's the medical team are doing outside. At the same time, to look of those that can have a kind of more acute psychological reaction that's beyond of the medical care. They would need a psychological basic approach, and also again take a look on the health staff dealing with that. So what we know that the normal chaos that you see during the scene, it's created stress for everybody involved. For those that are working inside the teams, outside the team, for the drivers, for the people, for the families. And I think there is a one way, and the mental health person could be also be a kind of mediator of this space, and to look how you can ensure that the people have the information and that they can understand what's happening there. I'm back to this topic about the families, and it's very good to have you here, Natalie, because that is an example that's again happened in Palestine during the COVID, and also mentioned the importance of the keeping the contact with the family. So, and the COVID everywhere, I think all the families face the same issues, that they cannot see, they cannot follow properly what's happened with their loved ones. And this case that goes through the international media of this the son of this woman, that they climbed the facade of the hospital every day during 1 month to have the opportunity to see what's happened with a mother. This is make this point for us to the importance of keeping the contact with the families, and to inform the families on what has happened, what's the course of the disease and the course of the treatment. I don't know if anyone wants to make a comment or questions. Any point in special?
I have like a question.
Please, please.
How can we do something? For example, if we are a medical student, what can we do for make this situation better?
Yeah. So I think that's I would say, Victor, that's the first step would be to review these materials that we have on the integrated psychological support or psychological first aid or mental health in emergency, because especially to have this idea that dealing with mental health or the psychological aspects, it's not something to be done only by mental health professionals. When you look at these protocols, you can see that, you can understand that, you can see how, I would not say simple, because it could be a subjective experience, or to think that's simple or not, but you can feel that it's possible. You can see that, okay, so now, from now, when I'm dealing with my patients, so you take these points to pay more attention, for example. That could be the initial point. The another point, it's sensitize other health professionals on the importance of that. And you have already a lot of literature on the importance on the address the psychological needs on the course of the different medical disease, and the importance of that for the patient outcome. And not to present the paper, but to talk to the people, and to share this experience, to ask the people and to share your experience that you had, that it was not to say that it's good or bad, that's not the point. So, but to say the experience that you saw, that there is a psychological component involved in your practicing as a doctor. So I think that it's very important. So we start to talk about that. You try to study more about that, and you start to talk to our peers about these issues. What do you think? Makes sense?
Yes, I think that that's a good point. We have to first get informed about this topic because it's very new and like that. So we, and you know, I think maybe we can say to the authorities or that's an important topic or
For me, it's cutting a bit your voice. I don't know if you only me or maybe could be my connection.
do you think well? No, I think that maybe it can be my connection. Do
Yeah,
you
but now I
listen
can
me
hear you.
well
Yeah,
now?
yeah, it's a
Okay.
bit slow
So, you know,
motion, but I can hear you.
okay, no, I'm saying that there is an important topic about the information. We have to first get informed or of all this topic because they are very new, and I think that we have to also say to the authorities or government about that the mental health is important and we have to take care of.
Exactly, exactly. That is very important, and it's very important that it's be said not only from the mental health professionals now, to be said by the health professional, the health service in general, and that we need to improve our capacity to respond on that, and because it's true, and you know what. There is another point when you start to be more informed and more able to deal with that. This is also plays a role as a coping mechanism. I have been working on the last 10 years with GPs and nursing in the primary health care exactly on the mental health topic. And what we see that for those people that engage on the training, on the capacity building, on the try to improve on the beyond of they do on their roles to have this understanding or to integrate the mental health in their role, it's also plays a role of self-care. They are less exposed to the acute stress when it's happened, and they are more able to deal with different kind of medical complaints, because from there they know the role of the psychological factors on that. So when you're talking about the capacity building, you're talking about information, there is one point that's capacity, but we already have evidence that it's also play a role as self-care, as a coping mechanism for the health professionals. So you study, and to be more able to do that, it's good for patient, but also as, let's say, self-protection. Can we move? You are seeing my screen.
Yes.
Yeah. Yes. Yes. I think we still have 20 minutes, right? Is it? I think we don't need that much, but I think that's maybe you can use this moment to do another exercise. I can ask any of you to read the test. It's about the case what's happened during the Beirut blast, the explosion of the port of Beirut in 2020. Can anyone read, please? Yes. Enas, it's right? I'm saying right your name?
Yeah, Inas.
Enas, please.
On 4th of August 2020, a large amount of ammonium nitrate stored at the fort of the city of Beirut, the capital of Lebanon, exploded, causing wide-scale destruction and mass casualties across a 5-kilometer radius. At least 200 persons were killed, 6,500 injured, and 300,000 displaced. The explosion took place at the Beirut port, the city neighboring area in Beirut, Ashrafia, Jemezi, and Quarantina, and Burj Hamoud. Nearly 70% of the capital, public and private infrastructure, 17 hospitals, 22 public health center, and 1 physical rehabilitation center were damaged, and over 120,000 people lost access to clean water. The country's situation is also affected by the series of crises ranging from economic devastation to sustained protests, the COVID-19 pandemic, and spillover effect from the armed conflict in Syria since 2011.
Thank you. Thank you for that. So yes, so the case of the Beirut blast, it's a typical situation that you can have an incident on top of other things that happen. So when you're talking about the events, we need to consider the context. So they are talking about one situation that's we already had at that time the COVID-19 pandemic, and also the consequence, the humanitarian consequence from the conflict in Syria since 2011, that's put Lebanon as on the highest grossing countries for the refugee in the world. So the country that had around 6 million and a half million people that receive more than 1,500,000 refugees. So we're talking about this situation that we are talking about one system that you are already dealing with these things, and on top of that we have this event. I want to ask you if you think about this situation or this scenario, what could be some proposals, what we can do to think, and we are here talking about the mental health. So what could be one potential lines to improve the psychological support of the mental health support in one situation like this? What do you think? Ideas, comments? Natalie?
Yeah, I remember when the blast happened, there were many videos about how the communities stuck together. They went out on the streets to clean the streets, and they stuck together. So, I mean, in times like this, I think one of the most important things is to have community support groups, so that people know that they're not alone and they can support each other, having similar experiences. And of course, it shall be under the supervision of someone who's a specialist in psychology or psychiatry. But just having the idea of community sticking together would help these people.
Yeah, to use this natural, let's say, community mobilization, and that you have the people that supporting each other and try to support that, right? So how you can help to structure this, let's say, this community engagement in the proper, let's say, peer support or basic psychological support space for the community that they can support each other. And of course, you can organize some groups and activities from that. So yes, definitively, it's a very good point. Other, Ines, please.
Yes. Also, I want to add to what Natalie said. Maybe if medical student or health workers in general have experience or education about how to psychological first aid. So when people have this kind of experience, they can help the people who are in need of help.
Yes. So to use these tools and try to involve the capacities available and even, yeah, I mean, the university community, that's the health professionals using the tools. So we have these tools exactly to guide us during this moment. So how you can include that? Yes, this is a good point. And also when you said about to think about, let's think about the multi layers perspective. You can have the basic supports, you can have this space for the community, you can have health staff, no mental health that could be trained and could be sensitized quickly with this guidelines or materials that could be very practical guidance or handbook to support that. And yeah, this is definitively a very good point. Other comments, suggestions, questions? No? Okay, let's, I just share with you quickly some lessons learned that we had from this experience in Beirut. So one, it's overall for the emergency response, it's to provide the hospital with urgent medical supplies on the health assessment. And the rapid assessment, it also includes the psychological first aid kit and or other kind of useful tools to support the teams to deal with the event. The coordination between stakeholders, it's essential to believe comprehensive and coordinated response. Sometimes we can see each organization working their own role and their own mandates, and it's very hard to have this coordination, but it's really important. The other point is to exactly what Natalie said. So how you can strengthen the social networks. So how you can involve the social network and provide the base psychological support. Consider that it's a proper space to think in the different modalities of attention. And also from that to identify those patients, those people that need to be referred to the specialized mental health service. We need the regular supervision and training for those people involved on that. So it's not about the one training that we do one day and halas, that the people know how to act. You know, we need to have this regular coach and supervision for the people to be able to be supported on the moments that they do this for the first time, and also to have the space to share their experience. There is one specific issue also that it's about the forensic advice. So how you can think about for support the families that are searching for the missing person, that's not identified, that they're missing, and also the management of the dead and adequate support for the families. So how you can also think to include the psychological, let's say the human components on dealing with these tough things. So And again, the importance of self-care. So we need to take care of those that are doing everything here. So we need to take care of the first responders. And that is super important because we need to take care of our health workers. I'm talking to you that could be used as health workers or managing a team in the future. And we need to take care of them. We need to understand the acute reactions to the distress. What could be the good of the stress that would make the people active and to be responsive when you have the situation, but also to think if the people become too much overwhelmed and to feel the balance on the work into other aspects of their life. So again, I think the key issue here is sometimes you cannot eliminate the stress, but you need to do the balance of the stress the people is dealing with. And here we're talking about the first responders, the professional, with their capacity to cope with that. So it's everything is about the balance. So we cannot eliminate totally the stress because the work it's sometimes it's about this, but you can improve the capacity, improve the coping capacity to deal with this, or to reduce the stress to do a better team management when the responder occurs. So when you think about the stress and try to put some explanation on that, because it become a kind of a generic word, we're talking about the basic stress. The basic stress, it's what we're dealing every day. So it's not a problem. It's, again, a normal reaction. So we can be in the kind of different moods according to the moment and according to the situation that we're dealing with. But there is something that can be more accumulative. It's something that you cannot release. Even if I take a day off or I can take a break, something that stay with me. So that become accumulative, that come from hours, days, years sometimes, when talking about the people that use not to be well connected with their feelings. And you come to the burnout. So the burnout is the moment of that you're burning and you cannot be functioning anymore, not for the work and not for yourself either. And different of the cumulative stress, we take the traumatic stress, that it's a moment that a health professional, they face one thing that for them, it's traumatic as an event, and then they cannot cope with that. So it's very important to understand. So what I'm feeling, what I'm dealing with, and to know my reactions. And if you are supporting or managing a team in the future, that could be the case for most of you in the future, to know how to read the people according to that. And the burnout, it's about that. It's the severe state of the emotional and physical exhaustion. So you cannot deal with the situation that normally we can deal with, but it goes from the excessive and prolonged stress. And you can come from the chronic physical and emotional exhaustion that could be irritability, and we can be the withdrawal, the isolation, also the sadness, the hopelessness about what you do in the work, and of course, it impacts your performance. I'm saying that, that's very important to look at this perspective, because when you look about the performance, you say, okay, it means that the person it's performing well, so he's not in burnout. Just when it diminish the work efficiency, that is the burnout. No, sometimes we need to, it's not about what the people deliver. It's about what the people deliver, but what the people keep for them. So how you stay after your work, how you stay after long hours on the tasks that takes a lot of energy, time, from you, and what are you taking from that day by day, day after day. So that is the main thing. So we need to take a look on these aspects, and because sometimes in the beginning of burnout, the people are quite efficient, but they're not doing well. So we need to observe and try to learn how to do this, let's say, self understanding, or this self-awareness about our feelings, about the weight of the stress that I'm taking from the work that I do. So I stop here. So thank you for the points, for the comments that you raise. If you have a question, I'm very happy to talk. Please. Thank you.
So Marcelo, thank you. Thank you for your time. And so guys, do you have any question or any final comments?
I see Anna's hand, but I think it's an old hand, right? Yes, it is.
I think it was quite comprehensive, and I mean, I hope they have grasped the whole idea of what mental health is and why it is necessary at all costs. And so thank you, Marcelo, and hope to see you soon.
Yes.
And it was nice to listen to you. And
thank you. Thank you for the opportunity. Thank you guys for the comments, and have a very good experience, and of course, a very good weekend as well.
Yeah, thanks. So we will continue because we have some other session. Thank you, Marcelo.
Thank you. Thank you.
So
Thanks. It was a very interesting topic.
yeah. So guys, now that the lecture is finished, we have one more session about the presentation. Do you need some small break? Or do you want to continue, because there was this group, if I remember? Can you hear, guys?
Yeah, we can hear.
You want some 5 minutes to refresh, and then we start, okay?
Okay.
So see you,
Okay.
yeah, after 5 minutes.
You can see here, we'll be talking about the purpose of pre-hospital response and also divide it into the general phases. Then we also talk about scene assessment and methane, which is the information, the way responders can also get information in order to respond to such situations. And we also discuss some important points to do after the assessment, like rescue chain and locations such as the advanced medical post, and then we explain the incident command system and then the main rules in it. And after all this, we wrap up to some key concepts in order to summarize our presentation. So
Okay.
before I go to the next slide, I would like to
one
ask
point I want to
everyone.
mention. Can you put the slides on full screen, like so that we don't see just see the slides? It's a PDF, so can you do it on show full screen or something? There is an option. Yes.
I'm trying to buy it. Appears this way.
Okay, so okay, you can continue.
Okay, thank you very much. So before we go into the next slide, I would like to ask, can anyone tell me what mass casualty incident is? Please, anyone, let's make it interactive.
It's an accident that we have too many victims, and something like that can be.
Exactly, that's what he said. So mass casualty response is a situation where there is a sufficient amount of casualties, and then the resources that are available or provided are not enough to cater for the needs and also take care of such casualties. And in such situations, if care is not taken, death and other serious effects can also do okay. So next slide. So this slide is talking about the purpose of medical response. And the first purpose is to help conduct rescues at the scene. Because in such situations, we are dealing with human lives and also properties and also other valuable things as well. So there is a need to also act very fast and very quick in order to help save lives and also prevent further damage to other properties or other precious things. So such rescue should be done as soon as possible and also done very well. So we should be very quick with time and also done very well in terms of quality. Then the second purpose of the pre-hospital medical response is to help transport victims to the hospital, because the hospital is where a lot of life-saving resources are available. So in order to have access to such resources, you need to transport or evacuate the casualties to the hospitals or other centers. And also in order to help limit the waste of life or the cause of death and other consequences that comes as a result of this. So here we are talking about the disaster response phases, and then we have the early phase and the steady state phase. So for the early phase state, that's where the disaster occurs. Let me say first, it occurs at is the response that is done or undertook when the disaster occurs on the onset. So at the early phase, you first confirm that the disaster is there. You set locations, then you also start field triage. We did triage. I think the other group, my colleagues did the triage the other time, and and then for the steady state phase, you complete the rescue chain, of which I will talk about in other slides, on the subsequent slides, and also take care of victims, and also evacuate the victims to the hospital in order to access resources in order to take care of their lives and also prevent other consequences. So I'd like to ask a question. What would you consider during an early phase? What would you consider during an early phase? That's the medical response. What do you consider in such a situation where there's mass casualty incidents? Please, anyone?
I think that first of all, we have to know what resources do we have.
Okay, any other factor else? Thank you very much, Victor.
I can see that it's always Victor who's participating in the questions. I mean, it's good to see him interact, but the others in the group should also participate. I see like some of them are like have never spoken, I guess. So it's unfair. I mean, you are here for learning, so you should try your best to participate in the discussion. Otherwise, it's just, boring. So we don't want to make it boring. We want to make it interactive and interesting. So please participate. There is nothing wrong in asking question, participating. Thanks.
So I think that's what Victor said. You also need to also assess the scene as well. So let's go to the next slide. So
I think there is a
scene
question.
The scene assessment.
There is a question.
The scene is where
from Natalie. Or a comment.
Okay,
Maybe.
Natalie, you can
No, it's
speak up.
okay. I was gonna answer this. He moved on, so it's okay.
Oh yeah, you can answer. You can answer.
I was gonna say we have to consider the number of victims. We have to consider the type of injuries that they might have occurred to them as a result of the incident. And yeah, just that.
Yeah, yeah, exactly. The number also matters because when you have the number to determine your plan and what to do to that will help save the number of people who are undergoing such undesirable situation. So for the scene assessment, the scene is where the incident occurs. So in order to take or participate in a response or an action that will help save lives, you have to first assess the scene so that you know the scope of what's happened there and also know the number of response or the quantity of resources that you need in order to undertake or save lives in such situation. So you have to consider the information that you need, then how you be able to collect them, and also how you're able to transmit
Clifford. I think something happened, so he's gonna join again. So we wait for him again. Okay, he has joined. Clifford, you can continue.
So you need information on what you need, information on what happened, and also how to collect them, and also how to transmit such casualties to the hospital in order to help save life and also prevent other consequences. So yes, here we come to the methane method. The methane method is the method that are used by responders in order to get and access information on the hazard or the information on the incident that happened and also how to go about that. So methane is an acronym that's defined for such method. So the M stands for the major incident, and the time. So an incident like maybe an earthquake, an incident like maybe a terrorist attack should be described or should be documented. So the name and also the time that it should also be noted down. Then we come to the E, which is the exact location. That's the exact location where in particular did we experience such incidents. We should be able to write the name of that location or the place. Then we come to the T, which is the type of incident. So in this type of incident, did it let me see, was it an earthquake? Was it a tsunami? Was it a terrorist attack? Then you name the type of incident that okay. Then we come to the H, which is the hazard. So you also help document the hazard or the factor that poses risk to people or the casualties that are around in order to prevent further consequences. Then we come to the E, which is access. So the access is the access to the hospitals, access to places or target locations where such casualties can be taken care of in order to prevent further death and also further injuries. Then we come to the N, which is number of casualties. So for the number of casualties, I think someone even raised the point when I first asked that question about the early phase stage. So the number of casualties, you have to also have a knowledge about the number of casualties that were obtained at the end of the incident or the unfortunate situation that happened. In order to help you know the resources and also the hands that you need in order to take care of such situations. Then also you come to the E, which is the emergency services. So the emergency services are the required services that are needed on time. They must be timely. The emergency services must be timely in order to help prevent further destruction to precious human life and also help save others. So in summary, that's the METE method. It's the acronym that's used in the systematic way of acquiring information about an incident which occurred and also produce a number of casualties whose demand for resources exceed the number of available resources that are there. Then we come to after methane. So after assessing all this information, what do you do next? So you do triaging. And for triaging, I won't speak more about triaging because my fellow colleagues did that the other time. And we have a fair knowledge about triage because time isn't on our side. I won't go much into triaging. Then you also have to set locations. So for the locations, you have to set the main location and the AMP, which I will talk about in subsequent slides. Okay. So here we come to the steady phase. And I would like to ask, what is done at the steady phase? Anyone? Anyone? The steady phase of the medical response.
I think that maybe it can be the part we put all the stage for the treatment of the patient, and also we coordinate how do we are going to transport and how do we are going to enter in the field for the treatment. I think that that's the point that we treat here.
Exactly. That's what he said, Ramos. Thank you very much. For the steady phase, that's where you basically transport or evacuate the casualties to places like the hospital in order to help save their lives and also prevent injuries and also even further casualties as well. So for the steady state phase, we have the rescue chain model. And for the rescue chain model, here is a picture which talks about the various stages that should be undertaken to help transport the person to the hospital. So in this part, here's the crash area or the scene where the incident occurred. So from there, then you undergo the rescue loop. And the rescue loop, that's where you have to collect the individuals or the casualties that were affected by the incident. So maybe if it was an earthquake, you help bring out such people from the incident that occurred, from the site of incident that occurred. So you help bring them out. And then after bringing them out, you help resuscitate them. So the resuscitation phase is where the first aid loop comes about. So you have to provide basic first aids. You have to check if their various vitals, like their blood pressure, their respiratory rate, everything is on point. And if there is a bleeding, you have to stop such bleeding and stuffs. So that's for the first aid phase. Then after all is said and done, some people may be extremely injured, or even they are at the verge of even losing their lives. So at that point, then you go to the AMP, which is the advanced medical. You go to the AMP, and then if all is said and done, then you evacuate them to the hospital. So the next slide, we'll be talking about the AMP, which is the advanced medical post. So for the advanced medical post, is a tent. It's basically a tent which is there to help place triage patients there. So that's where triage patients are placed. And also it must be very secure from where the disaster occurred. It must be a secure area from where the disaster occurred in order to prevent if any disaster occurred, maybe if it was an earthquake or a tsunami. Another one can also occur after the first one. So it should be secure of a little bit far from where the disaster occurred. And then the place should be also accessible to vehicles and also airflow, which is ventilation, because from the advanced medical post phase, you are transporting the person to the hospital straight ahead. So you need a vehicle, a means of transport in order to transport such people to the hospital. And also ventilation should be provided, or enough ventilation should be provided, because in situations like an earthquake, people suffocate or they remain in enclosed spaces for some time, and they may be lacking oxygen, or the oxygen content in their blood may be very low. So you need to provide a maximum amount of ventilation in order to allow them to breathe very well. So at this stage, okay, so here's also why the so for here, this slide is talking about how necessary the advanced medical post is to the whole process of pre-hospital response to mass casualty incidents. So why is it necessary? The number of victims can be too high to provide rapid evacuation. So when you provide a safe place like the advanced medical post, where the place is there to resuscitate or support such individuals, it helps in evacuating them at a very rapid state. And there's also the need to stabilize such patients before evacuating them to the hospital. So as I said earlier, in cases like earthquakes, for example, people can suffocate and then leading to low amount of oxygen levels in their blood. So such people need to be stabilized. They need to be provided with enough air to breathe in order to sustain them. So in doing that, you have to stabilize such patients before they are further taken to the hospital. And also the hospital can be far away from the site, and also the transport of very critical victims would be very dangerous, because if, like the example that I cited for an earthquake situation or even a flood, the person or the injured person, or let me say the affected casualties or the casualties, can be in a very critical state where they will need a first aid to help sustain them, and also need some basic requirements, some basic support to help sustain them before they are taken to hospital. If that's not done, even on the way to the hospital, they can even die as a result, making your work as a responder to such incidents a zero work done. So that's the need for the advanced medical post. And also there can be a few number of ambulances available. So in such states, you have to also help support such patients or such casualties before they are transported to the hospital. So at this point, I will let my colleague Carlos continue with the other slides. Thanks very much for your audience. So Carlos, can you please continue for us?
Keep in mind that you are already, the time is running out. So because we had this interruption of. So Carlos, you should continue.
Okay, thank you. Can you put next, please? Okay, it's so important that we know who is in command, who you think in this scenario that the person is command in this post. Who you think? Any?
Maybe it can be someone that have experience in these cases or in these casualty incidents.
Okay, thank you. It's so important because that we think that the person in command is the person with most experience in all these team. It's so important that the people that is command know about disasters, about the topic. In this case, it's very important. Next, please. Next, Clifford. Hello. Next. Uh-oh.
Next
Clifford.
slide, please. Next slide.
Oh, Clifford. Maybe can I share my screen? Okay. Okay, so it's here we can see the roles in all the advanced posts. We can see a medical incident command, triage officer, ambulance loading officers, advanced medical post supervisor. We can see all the function about these roles in next slides. Next, please. Okay, a medical incident commander have many other responsibilities. You can see on is in medical rescue coordination and communication. It's important that the person is identified. All the people in the scene can see that this person, sorry, is the incident commandant. It's important that maybe use a jacket or a suit that you can see that this is the commandant. This person orders and manage all the resources they have in this position in the same and support of different rescue chain supervisors with all maybe will also work and function in this system. Next, please. Other roles that have the medical incident commander is stays in one location. It's important that this is important because the people may can say and know where is the incident commander. It's important that this person stayed in one location. This can be for the persons more easy the work in the scene. It's important that this person is easier to identify. This person overall a picture of the scene. This person may say no. Where is the scene, location, access routes, and all resources have it in dispose type of accident and number of victims, number of hazards, the type of hazards. It's important that this person have all the knowledge about the system. Uh, this person may designate personnel to from start trash and designates area for all the patients, or the area for stay in a different type of trash on routes of evacuation of these persons and order evacuation of these persons. Next, please.
Sorry, you have 1 minute left.
Okay, thank you. We have a triage officer. All responsibilities is access of the number and severity of patients, zero triage areas. It's really important for this person and communication with the medical insane coordination and coordinate triage teams and respective operations. Next, please. Next slide, please. Clifford next. Next slide, please, Clifford. Clifford. Have problem with Clifford next, please. Okay, so other role we have next is like advanced medical post supervisor. These responsibilities organize different severity treatments areas and advanced medical post, coordinates medical management of patients, and show definitive destination of patients. They visit the person can go to hospital of patient, the chairs, maybe the person can walk or other treatments. And other roles, ambulance loading officers. This person have the responsibility to organize boarding zones, coordinate boarding operations, and keep record of the patient on vehicle on airflow, depend of resources they have in the descent. And we can see. Clifford, you can next slide to the pre-hospital diagram. Three. Clifford, you can hear me?
What I see is it's a very slow, communication.
Yes. Maybe he can hear us.
But I think you should just summarize, because we are way too behind our schedule. So it's better that you just summarize, and then if there are any questions.
I have a question. How is the best way to put like the order in order all that team? For example, sometimes when we are in a mass casualty incident, we have a problem that we can't communicate better, or we can select who is going to be part of, or who is going to be in charge of some parts. So what is the best way to make the Do I listen well?
What's your question, Victor?
Sorry for my connection.
Is echo.
Okay, can you please repeat the question?
I was asking if I was asking, for example, how is the best way to organize all the team when we have a mass casualty incident? Because sometimes we have communication problems, or we have problems with the selection of the people that are going to be in charge. So what is the best way for organize this kind of?
This is to the group that is presenting, right?
Yes, someone from the group that wants to answer. If not, I can take the question, but please, the group Who wants to answer the question? How to organize the team in a mass casualty incident when you may have communication problems?
Okay. Okay, we can organize the people who have problem with communication. It's important. We can classify what type of communication problem we have. Maybe in this case, for example, we have many language or different language. It's important first that we try it that we can speak in one language. In this case, is for English, for example. And maybe if we can problems with the network, with the internet, with the signal of or maybe our phones or on or radios, it's important trying that search one place in the scene that we can locate this person that can communicate with police, with the firemen. The person stay in the better place that he can or she can communicate with other peoples. Yes, I think this is the first step. Maybe in when we have other problems of communication, we can talk with all the people, maybe conversation about that thing, about we can hear maybe brainstorm for organization or of the scene before start all the management about this scene, about the about the advanced medical polls. Maybe we can.
Okay, I will stop you here because some of your answer is not really correct. Regarding so your question, it can be divided in two. First one is how to organize the team, and then how to organize the communication if there are problems. In both cases, the organization should be done before an event. So this is part of the planning phase. If you remember the disaster cycle, before the response, there is the planning phase. During the planning phase, each structure that is responding, so if we talk about an ambulance service, if we talk about a hospital, if we talk about a region, should have a plan on how to respond, sorry. And this plan is not individual based. So in the plan, it doesn't say Victor will do that, George will do that, and Farman will do that. Instead, there are some roles there. We need a medical incident commander, we need a triage officer, we need an evacuation officer, and so on and so forth. So you come with this incident command system, which is the backbone of the organization of a team in any disaster, especially in sudden onset disasters like a mass casualty incident. So this answers the question about how to organize the team. So you organize it before and you organize it according to the incident command system ideology. It's not something that you brainstorm. If you brainstorm, that means that you haven't planned accordingly, and that would lead to a very poor response. During a disaster, especially during a mass casualty incident, all the organization needs to be military-like. So we don't brainstorm, we don't try to see who would like to do that. If you remember, we discussed this in the simulation, in the first simulation that we had, that you need to appoint people, not to brainstorm and think about what would be the best. You do that before, not during an event. And regarding the communication, the thing is that during a disaster, during a mass casualty incident, usually there are no real communication problems because everybody has radios, and if not, the telephone network is working well, there are no problems. But if you think about an earthquake, for example, that can destroy the communication infrastructure in a region, then it can be a problem because you could only use, I don't know, satellite phones, for example. But in any plan, this is again part of the planning, there have to be alternative way of communication. So everybody usually have radios, you have your own phone. If these die, what do you do? Basically, an alternative is to use short range radios that do not need external antennas or external services. So basically, these are the basic walkie-talkies that you can buy, I don't know, to play around with. And they communicate just one to another. They don't communicate via satellite. So they don't need any external device to be used. They only need battery and that's it. So this is one very good and widely used alternative to communication in mass disaster settings. But of course, this is just temporary. Did I answer your question?
Yes, it was more about when we have destruction in our communication structures. So yeah, thank you.
Yeah, you're welcome. Any other questions? If none, due to the time, I would suggest to postpone the next presentation, so the hospital, the presentation about the hospital preparedness for the next session, if that's okay with the presenters, because otherwise, I know that also your presentation is quite long, so we will go over the time quite a lot. Do you agree to do that, or would that be a big problem for you to postpone it for the next session?
It's okay with me. I don't know about the rest.
Yeah, I think it should be okay with me as well. But does that mean like the other session would be longer?
Not necessarily, because theoretically the other two presentations that will be during the next session will not be so long. So the presentation that we had today about pre-hospital and then the one with the hospital preparedness, these are the longest in the whole ITDM. The others are not so much in detail.
Okay.
But we'll also talk with the others that will present next week, and if they think that they would need more time, then we'll announce you if maybe we'll extend the other session with half an hour maybe. But we'll let you know on the forum, on the platform. Is that all right?
Yeah, I think that's okay.
Okay.
I have one thing with this
For
group.
me,
I have to ask one thing.
no problem.
Okay.
The group
go on, Farman.
The group who was presenting, it seems like there are only two people who were engaged in the teamwork. Can they explain who were involved?
Yeah. We're supposed to be four members, but one unenrolled from the program.
Okay.
So we were left with three, and the other two is having a finals today. He's having an exam, but he said he would join if he finished earlier, but I'm sure he didn't finish early, so he wasn't able to join. So that's why we were two in this presentation.
Okay, thank you.
Okay. Farman, if you have any feedback for the group?
Well, I think there were problems in the presentation in terms of the technicality. First of all, the presentation was in PDF. Okay, it's okay if it is PDF or whatever, but I mean the best way is to present through the PowerPoint. This way we can only see one slide. So there were problems in that. And then there was this internet problem. Clifford has to reconnect 3 times. So it was like we lost a lot of time in that. And then again, when Carlos was presenting, there was this lack of, because he has, I think, maybe weak connection, Clifford, and it was like, okay, it was not moving. So we couldn't, I personally, I was very focused, but I couldn't get any points, and they couldn't finish, although they took, like, I would say more than 45 minutes. So it's like, I think these things they need to focus for whenever they present individually or in groups, that you need to take the time very seriously, and you need to take the slides very seriously. And I see it's like, I was comparing the slides with the previous slides. It's almost the same. So, I mean, there should be some innovation, from your side. So these are things, these are the things that you need to learn. And time management is very important. If you, like right now, we did it here, 50 instead of 30. So it should not be the case for the next groups. Also, it's also a warning for the next groups also, because it makes things very difficult. Now we are canceling one for the next time. So please keep these all things in mind, and it's be very specific. So I hope this is clear to them.
Okay. From my side, first of all, congratulations. It's a hard presentation, but it's one of the most practical and important from the whole ITDM, in my opinion. If every student, medical student, would know the notions that you presented, we would live in a better world, in a better place. So congratulations for that. It wasn't easy, especially that you were only 3. Additionally to what Farman said, I would just add that I kindly suggest you to maybe read a bit more on the subjects that you are presenting, besides just the information that's on the slide. Because next time when you will get these questions, maybe someone more experienced won't be there to help you. And it's very important to answer appropriately and correct to the questions. So please pay attention to provide correct information, because otherwise it doesn't really make much sense to teach. I mean, if you are not sure, you better say, I don't know that answer. I will read and come back to you, instead of saying maybe something that was not really accurate. Okay. Anyone else from the group that would like to say anything? Okay. If not, I wish you a very nice day, and we'll see each other in the next session.
Okay, bye guys, and have a good weekend. Okay.